Hello, everyone. My name is Samir Mehta. I'm an orthopedic traumatologist at the University of Pennsylvania, and it's a pleasure to join you today as part of this session. I know you've already met Dr. Dasa, and he'll be joining me in this session on the economic insights associated with non-surgical treatment strategies. These are my disclosures, and these are the learning objectives for this part of the sequence. We're going to talk about costs associated with surgery and conservative treatment for fracture care, particularly in non-unions. We're going to discuss the use of orthobiologics as an adjunct to surgery and how these treatments can impact outcomes and reduce cost. And we're going to also outline how racial inequities impact the clinical and economic outcomes of osteoarthritis and total knee arthroplasty. So I'm going to start off with a case. I always like cases because I think it frames the discussion a little bit. PR is a patient. She's a 51-year-old female. She happens to be a nurse that works at an outside hospital. She fell and she slipped on ice and she had an open tibial shaft fracture. And this is what we call a type 1 open tibia, so it's a fairly benign open fracture, if you can consider open fractures benign in the grand scheme of things. This is her original x-ray. You can see it's a fairly simple fracture pattern. It's a slightly oblique tibia fracture with a very small wound, and she was treated with an intramedullary nail. Again, standard of treatment. It looks like it was done technically well. She received some antibiotics. Of note, she is a diabetic, so she falls into a little bit of a higher risk category, and she does have an elevated BMI, so she is a little bit, from a weight perspective, a little bit bigger. 9 months later, she shows up in my office with this on. So you have to wonder what happened between her original fracture care and fixation and then into this external fixator, ring fixator. There's lots of things that sort of happened in between, which I don't have access to, but you can see that her bone does not look great. Her bone quality is actually looks quite poor. And her ring fixator shows that she's got just a little bit of malalignment. Her fracture still isn't healed 9 months later, and now she's got some draining wounds as well. So this is really complicated now. It went from being a relatively benign issue to a much more complex issue and becomes a little more risky. She's draining from her pin site. She has no callus formation, and her soft tissues look really poor at this point as well, and she's clearly infected. So we take her back to the operating room. Now she's my patient. I take off the ring fixator. I put in an antibiotic nail. We cut out that entire segment of infected dead bone and put in a cement spacer, which is what you see that circle around. And I put in an external fixator to give her some stability as well. That's what her soft tissue looks like. You can see the huge intercalary defect she has from that's tibia down here, that's normal. That's tibia up here, that's normal. That's an antibiotic nail in the middle, and that's a cement spacer that we're putting on around that to give the local soft tissue some control. You can see the infection from the pin sites around her bone, around her soft tissue as well. It's not a pretty picture. And so this is her 8 weeks later. We put her in a different kind of ring fixator. We're doing a bone transport. This is her 11 months in. She's made some bone. She's got a wound that's not healing. I've got my plastics folks on board trying to get her to heal. And this is her at 14 months with a below the knee amputation. And so you say, well, wait, how do we get from a simple open tibia fracture to a below the knee amputation? And over 23 months from her index injury, she had 9 hospitalizations. She had 24 clinic visits, including infectious disease and home care. She had several treatments with IV antibiotics, which led to renal failure and neutropenia. She had 7 surgeries, and I can't even begin to calculate the cost of care in this scenario in terms of ICU time and surgeries, et cetera. And I bring this up because you have to wonder what the economics of this are. And I don't like to look at patients as dollars and cents, but we have to think about what our decision-making and how our decision-making impacts ultimately our ability to deliver care to everybody. And so we're going to talk a little bit about the economics of non-union fracture care, because non-unions are very common. Non-unions happen in about 10 to 20% of patients who have a fracture. So it is not uncommon for a patient to not have a fracture, that doesn't heal. And so managing that becomes really an important thing. Here's a gentleman who was involved in a sort of an accident at home. He was changing out his water heater or working with his gas pipes, and something triggered a fire and it blew up and it created this fracture, and that's part of his fracture pattern. You can see the devastation to his lower extremity, and this is not a trivial injury to treat. And when you think about algorithms for treatment, this is the algorithm for treating an open tibia fracture. So it's not clear and simple decision making. There's lots of breakpoints and decision points that need to be addressed. And as we look at this tree, we realize that there's a lot of opportunity here to intervene and prevent, hopefully, an event like you saw with our previous patient that leads to an amputation. So the question is how do we get to taking a complex injury or even a simple injury and getting them to heal without going on to a non-union? And when we talk about non-unions, we look at a patient like this. This is a 16-year-old. She's a college athlete. She was at college when she broke her femur. She plays tennis at a Division I school. She had a rod put down her femur. We can argue about the type of rod that was used and should it have been used, etc. But this is the type of rod that was used. And this is her at 6 weeks. And while it's only been 6 weeks, you say, well, it's only been 6 weeks. She's totally healing. She doesn't need any intervention. I would argue that a femur that starts to look like this may not be healing, right? So that's her at 6 weeks, and it kind of looks a little weird. And so, we talk about what's a non-union. So how do we define non-union? And there's different ways to do it. Some people say it's 3 months after an injury without healing. Some argue it's 9 months after injury. You can go through these numbers, but ultimately, when we talk about non-unions, I think about Justice Potter. Justice Potter was a Supreme Court justice who had a famous saying around the concept of pornography. He said that he doesn't know how to define it, but he knows it when he sees it. And so when we talk about non-unions, I would argue it's the same thing. I'm not sure how to define it, and there are different definitions. The one definition that's commonly used is no significant callus formation in 3 successive x-rays that are 1 month apart. And so when we look at this patient, yes, she is sort of showing bone formation every time we see her, but she's not uniting. And at her 6-week x-ray, I was already concerned. And this is her last set of x-rays was done at 6 months before we intervened. She was complaining of thigh pain. She felt instability. It did not feel right. And so she went on or went to a non-union, but at 6 weeks, she was already showing signs of it because it's a femur. And so if it smells like a non-union or it looks like a non-union, you have to be concerned that it could be or is a non-union. And there's several factors that impact fracture healing. So when we think about fracture healing and non-unions, why do people get this? Yeah, it can be the blood supply to the bone. So in this scenario, in this picture you see here, this is a nun. She had a rod put down a femur fracture. Several cerclage wires were used, and those cerclage wires strangulate the bone, and it's possible that the cerclage wires, affected the blood supply to the bone and led to her non-union. We know that biomechanics affects fracture healing. So fractures that are fixed well versus those that are not fixed well or overfixed can lead to non-unions. Obviously, infection can lead to the bone not healing. This is a patient who was hit on the interstate and was fixed, but he had this draining wound and was draining for months. And if you look at his x-rays, clearly he's not healing, and the infection can cause that. And then there's things like host factors that will put people at risk for not healing. So these are things like smoking, diabetes, vascular disease, if they take certain medications. So there are things that, if they have a thyroid disease, so there are certain things that biologically put these patients at risk compared to other patients. So when I talk about my level 5 approach, and I say level 5 somewhat tongue-in-cheek, I do have a process when I look at a patient in terms of how I approach this to either prevent or manage a non-union. I think the biggest issue is anticipation. So you're recognizing patients who are at risk, whether it's their injury mechanism or whether it's their protoplasm. They may be like our first patient that I showed you and ended up with an amputation. She was a diabetic with an open fracture. This puts her at risk. So anticipation is really key. Prevention, so doing things before they get to the non-union is really important. So this is things like good soft tissue management, diabetic control, making sure they're taking vitamin D to help with fracture healing, using things like lipase to help fractures heal, because one of the other things I tell my residents when I teach them all the time is fracture healing is a race. It's a race between the fracture failing or the hardware failing that's holding the fracture together and the bone uniting. And so eventually all hardware will fail. That's a fact, right? All hardware will eventually fail. It's really a matter of when. And so when we approach patients who have or are at risk for a non-union, I think doing what we can to prevent them is really key. So identifying a non-union is really important. So getting x-rays. So these can be hypertrophic, which means they're making bone, like the tennis player I showed you. She was making bone, but she just wasn't coming together. Or atrophic, which means that they're not making any bone, and there may be a biologic reason for that. These patients also require time. They require time in the hospital, and they require time in the clinic. They require a discussion about what's happening. And one of the things that one of my mentors used to tell me was the difference between an excuse and an explanation is timing. And so if you tell a patient in advance, listen, you're at risk for a non-union. You had an open tibia fracture. You are a diabetic. You had a bad soft tissue envelope. We did X, Y, Z for you preoperatively or intraoperatively. We've put you on the LIPUS postoperatively, but you're still at risk. Then it's not a surprise. They also need to help sometimes be taken through the decision-making involved in fracture healing and in what the options are as they are not healing. These patients all require an infection workup. You know, infection is the great imitator sometimes. And so even if they don't have a draining wound or a big open, you know, they're not septic, you can still have a low-grade infection. And so an infection workup is really important, along with a metabolic workup. So understanding their biology. And we're learning more and more that a patient's biology is really important in fracture healing. And then I don't think there's much role for advanced imaging, but you can get a CT or an MRI if you need it for your pre-op planning, but advanced imaging may not be of tremendous benefit. And then lastly, these patients require a tremendous amount of planning. So when I look at my non-unions or take care of non-union patients, there's a lot of planning that goes into it. And so as we think about this and we think about fracture healing, we know that there's a lot going on in the backdrop. And I don't begin to even get into the science of fracture healing. I am not a basic scientist, but I recognize that this is a real complex interplay of multiple things. One of the things that this slide reminds me of is we hear about people putting in different biologics. They'll put in a single protein, and I think about fracture healing like baking a cake. I would never bake a cake with just a bunch of flour or just a bunch of sugar. I would have multiple ingredients, and I think fracture healing is very similar to that, which is why I think certain treatment methods make more sense than others if they're ramping up the entire pathway system, not just one particular protein. We know that there's a tremendous economic burden of non-unions, right? So we know that 10 to 20% of patients will go on to a non-union. We know that non-unions are a multi-billion-dollar issue in North America. And so we also know that as we think about non-union management, when patients go on to have a symptomatic fracture that hasn't healed, that patients who are treated with surgery actually have higher medical costs than patients who are treated with low-intensity pulsed ultrasound. And that low-intensity pulsed ultrasound is a cost-effective alternative to surgery. Now, not every patient is going to be able to be treated with low-intensity pulsed ultrasound, frankly, because they may have a fracture that's failing or they may be infected. And so there are other reasons to do surgery, but from a cost perspective, there may be a direct cost benefit to utilizing low-intensity pulsed ultrasound. Some argue that, well, what if you already have metal in place? Will that affect the ultrasound from getting to the fracture, or will it affect the ultrasound waves hitting the metal? And we know that ultrasound and metal can work together, that there's no deficit from having metal in place, and that we can treat a patient with a non-union who has metal in place with ultrasound. There's lots of evidence about non-union treatment in patients who have been treated with ultrasound, patients who've had long-standing non-unions, and their only treatment is ultrasound, showing that you can take a patient who's had a non-union for 1 year, 2 years, 3 years, and be able to treat them with ultrasound, assuming they have a stable fixation, they don't have infection, etc. In this study, they showed that it was a prospective series of 29 non-unions of various types: atrophic, hypertrophic, oligotrophic. The fracture to age was about a year, and they'd already failed surgical treatment. And you can see with ultrasound that a large percentage of these patients healed. Even the high-risk patients, like the smokers, healed with just ultrasound treatment. Another prospective case series of 67 non-unions. Again, these long, sort of drawn out non-unions. Ultrasound treatment was the only treatment rendered. 82% non-union heal rate. I will tell you that if I could get, and I could promise my patients, 85% heal rate with surgery after a non-union, I would take it. So, these numbers are comparable in some ways to what we get surgically. This is a randomized controlled trial showing that it was increased bone mineral density in patients who had a non-union treated with low intensity pulsed ultrasound. In this case, it was exogen, and there was a high compliance rate. So all of these things are showing us that treatment with ultrasound actually makes a huge difference in terms of bone mineral density and healing. A meta-analysis showed that the lipus heals non-union fractures. And so this took data from various sources, the meta-analysis, right? So it took data from multiple sources, sort of collated all that data and showed us that non-unions treated with ultrasound, some of the data I've already shown, but this is sort of bigger, showed that fractures can heal that way. Now, I want to be mindful of the data that I share. This was a study published that showed that there is very little impact of ultrasound in all tibia fractures treated with ultrasound, low intensity pulsed ultrasound. Now, the reality is that when you look at this study, they treated all patients, not high-risk patients, not non-unions, and there was variable utilization of the ultrasound device. And I think that's really important. We know that if you use this and use it the way it's supposed to be used on a consistent basis, on a daily basis, that it can improve fracture healing. But there may be limited use in those patients who are not high risk or don't have a non-union. That still needs to be determined. But in the scenario of a patient who's either high risk or a patient who is already a non-union, there's clearly value, and the data has shown that. So I love this slide because it reminds me that data is really born to some interpretation. It's parachute used to prevent death and major trauma related to gravitational challenge, systematic review of randomized controlled trials, and the caption in this British Medical Journal article says, parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized controlled trials. And I find that very interesting as sort of a somewhat comical, but also reminds you that not everything can be or has randomized prospective studies, yet we still comply to it. So I think it's important for you to weigh the evidence as you think about what you're going to do and how you're going to do it for your patient. So I'm going to share a last sort of scenario with you, a last case with you to kind of show you how complex these patients can get. This is a gentleman who was injured back in 2008. I didn't treat him initially. He was treated in an outside hospital after a motorcycle crash with an intramedullary nail device. He went home with a low hemoglobin, and it turned out that he was bleeding from his fracture site, and he was taken back to the outside hospital for an emergent vascular repair where they did additional surgery to him. And then he went back again about a year and a half later because he wasn't healing, and they put BMP into his fracture site to see if they could get him to heal. He comes to see me almost 3 years later with hip pain, not femur pain or thigh pain, but hip pain. And he's got about a 3 centimeter leg length discrepancy. So clearly, he doesn't feel good. His hip is bothering him. And, at this point, people think it's his leg length discrepancy, but as you do a deeper dive, his fracture is actually not healed. And you can see the fracture line. If you look at this image, you can see that there's a fracture line that goes through it. You can also see how this bone just doesn't look normal. So I did a non-union workup on him. His vitamin D was low, his testosterone was normal, and he had a normal infection labs despite having this sort of infectious type picture. He had multiple surgeries to the site, and maybe I should have treated him like an infection patient. So I had a long sort of discussion with him and myself about what to do, and ultimately I did a 2-stage procedure. I assumed that he was infected and said, listen, we're going to treat you like an infection. So we debrided the non-union site. You can clearly see it in this fluoroscopic image from the operating room. We used an antibiotic nail. We did a 2-pin external fixator, and his intra-op cultures were negative. So I said, all right, so you're not infected. We're good to go. I then took him back. I put a rod down his leg. I took out that intercalary segment of bone that I was worried about, that I didn't think was alive, and I put a cement spacer in there. So I put an antibiotic cement spacer, again, with the idea that, well, maybe he's infected and this bone isn't great. And you can see that maybe I got an incomplete resection, but I thought it looked pretty good. I then filled this with bone graft. So I brought him back again. I took out that cement spacer and I put bone graft in there. And then our decision was, let's get you to heal your femur and then we'll lengthen your leg over time. He said he was feeling great. He had a stiff knee, but I wasn't impressed by his bone formation. And so about 6 months after I started treating him, he felt a pop in his hip. And you can see that he broke the screw at the top of the femur. So unfortunately, he didn't make enough bone here to maintain the gap and fill in the gap. And as I said before, all fractures eventually fail. And so you can see here, he broke the screw at the top of the nail because the fracture failed. Okay, he had more pain. I wanted to give him some time. Let's get him to heal. I can always lengthen him later. But ultimately, you can see he's shortening. Now the nail is sticking out farther. There's more displacement. He's got more pain. I haven't used any ancillary treatments like bone stimulation or anything like that at this point. Now he's 6 centimeters short. I've revised him. I've tried to get him to heal. So I now back to the operating room again to see if I can get him to heal. So I just put a new nail in. I leave him shorter. Just again, the idea is to get him to heal, and then I'll get him out to length. He feels great. He's got no pain. His fracture's filling in, and he's ready for lengthening. And I sort of buried my head in the sand a little bit, because if you look at that x-ray, and I'm looking back at this case as I show it to you, I'm like, what was I thinking? But I'm convinced myself that, yeah, he's healed enough that I can start lengthening him. So I take him back to the operating room, and I start to lengthen him, and I make an osteotomy above the area that I think is healed. So here is where I make the osteotomy, and I put him on a low-intense pulsed ultrasound device 20 minutes a day to see if I can get him to fill in that bone distally down here where the other sort of bone grafting was. So he starts lengthening. He has no complications. He's following his instructions. He's weight bearing. He's feeling good. You can see that he's lengthening his osteotomy site, and he's using the ultrasound. Well, the ultrasound's really effective, so effective that actually he starts to consolidate his osteotomy site, and he's made so much bone at the osteotomy site, but I'm still pulling. He pulls through the site that hadn't healed, and that was not really great bone. And so my ultrasound worked great to get the osteotomy to heal, but it healed way too fast. And so I take him back to the operating room. Once he's out to length, I put a new nail in him, and I took out the old interlocks, and then you can see that he's filled in his osteotomy site, and he's starting to fill in his other fracture site. I have a video of him jumping that doesn't play very well because I think I lost it, but I have the screenshot from it. And this is him. His leg lengths are equal. He's showing me how he raises his pants up and his shoes look great, and he's jumping on it. But then he feels some pain, and he feels a pop again, and he never healed that intercalary defect. He had stopped using his exogen and really was sort of thought he was over the hump, but he really wasn't. So after all of that, I take out that area of bone that has not been healing. I shorten him again. I put in a new nail. I put him back on the ultrasound. I lengthen him over time. I finally get him out to length. You can see the bone formation that's happening with the ultrasound and the new rod. And ultimately, at 6 months after this surgery, 34 months after I saw him, I finally get him to heal. And I share this case with you because it shows you the complexity of fracture healing and all the things that go into it, and also all the things that can go wrong. So he had 47 months, 8 surgeries, and 40 office visits to get him to heal, and with a lot of adjunctive treatment. And I think the adjunctive treatment made a huge difference. So I want to thank you for your time and your attention. I know that's a lot of information there in a very short period of time, but hopefully it gives you an insight into some of the complexity involved with these cases, and also how certain things can help facilitate the healing of these fractures before they get to this really complex scenario. I'm going to turn it over to Dr. Dasa now for the rest of this particular session. Thank you.
Thanks, Samir. So next, we're going to talk about racial inequities in the management of knee OA and total knee replacement. So this is a space that's near and dear to my heart and our research program here at LSU, because for good or bad, Louisiana has a significant amount of health disparities, and obviously it's coming to a head right now in real time around the US and actually worldwide. So Louisiana, we have the second highest percentage of Black Americans. We have, unfortunately, a significantly high number of individuals that live below the poverty line, and a significant number of patients that are on Medicaid. And with Medicaid expansion in Louisiana, we saw a lot of the health disparities and the inequities really become much more apparent than they have in the past. And so over the last few years, our department and our research program has really put a lot of emphasis and resources into understanding health disparities and their impact on outcomes. So osteoarthritis in general is the most common joint disorder in the US. 2005, 27 million Americans suffered from OA. You can see the gender demographics here. It's more common in women. And obviously, as you get older, we would expect OA to worsen and become more commonplace. So osteoarthritis is the loss of articular cartilage within the knee. The analogy I use with a lot of my new patients that come see me that have OA is it's similar to when you snap open a turkey joint during Thanksgiving. You see that smooth, white, shiny stuff. When you do that, imagine you took a fork and started scraping it away. That's called arthritis. And so some of the other anatomic changes that we see are osteophyte formation, inflammation, attenuation of the ligaments, so on and so forth. And the most common clinical features are stiffness, difficulty with ambulation, trouble going up and down stairs, decreasing range of motion, deformities, things like that. And so when we look at OA, non-modifiable risk factors are listed, and the modifiable risk factors are somewhat up for debate. And can you really, in a lot of patients, really impact the obesity issue? You know, we've all, as clinicians, struggled with getting our patients to lose weight. Probably a lot of us ourselves have struggled with doing that. So, you know, traditionally what we think are modifiable risk factors, even smoking. How do we manage that, and how do we deal with that? And truly, is it really practical to withhold treatment or withhold surgery until they fix these things, which many of us struggle to fix ourselves? When we look at the paradigm and the treatments of osteoarthritis, obviously we start with a non-operative and non-surgical management first, weight loss, exercise, physical therapy. Then we start becoming more and more aggressive with over-the-counter and then prescription-based treatments. And then we get into more interventional-based treatments and then ultimately surgery. So I think as an orthopedic surgeon and a subspecialist, a lot of our patients have really failed these first two steps before they come to see me. If those steps work, they probably would not have come to see me. And so oftentimes patients hit my office or hit the specialist office really here. And so what are the opportunities to intervene after they failed a lot of these kind of pre-specialty treatments and interventions, if you will? So total knee arthroplasty is the most common surgery performed in the United States, and it's growing significantly. Most everybody knows hip and knee replacements. The trajectory of those surgeries is significantly growing. And so how do racial inequities impact all of this? And so if we look at the health economics data, the inequities and the disparities that we see Black patients or non-white patients exposed to really cost the system a significant amount of money. And so if you look at direct and indirect medical expenses, you can see how much money truly is being wasted purely because of the color of somebody's skin. And so there's an economic imperative, not just a moral or ethical imperative to really fix what's been going on for centuries, but there's really an economic imperative as well, motivation. Now that reimbursements are going down and value-based care is here, we're talking more about population health and managing communities. So we have to fix this from an economic perspective as well. So if we look at the impact of racial inequities in management of knee OA, this is a very large study that's been ongoing for some time, the Johnson County Knee OA Project. This was a study looking at differences in OA in Black patients versus white patients. And we see no difference in incidence of OA between white and Black patients. In other words, OA is happening equally between both groups. But what we're finding is degree of progression and the manifestation of OA is worse in the non-white patients compared to the white patients, even after we compare control for all the variables that you see listed. So this was another retrospective chart review looking at the difference in outcomes in our surgical patients, Black patients versus white patients. And what they found was utilization of both hip and knee replacements significantly higher in white patients compared to non-white patients. And then when we look at complications following surgery, you can see here, not just getting the surgery was a barrier, but actually after you have the surgery, we're seeing significant differences in complication rates in Black patients versus white patients. So if we do a deeper dive into those complication rates, what do we see? If you look at UTI, PE, DVT, renal failure, sepsis, we see a significant difference in our non-white patients compared to our white patients, even after controlling for all the variables that you see here: age, sex, smoking, medical comorbidities, so on and so forth. So there's inherent bias within the system that goes well beyond the actual biology that we when we try to explain what's going on. When we look at another retrospective chart review, and we look now at revision joint replacements and the impact of race and inequities on this, what we see is a similar trend, right? A higher utilization in white patients compared to non-white patients. We see the same thing in revision knee replacements. But what's concerning here is actually in the revision space, we see more Black patients getting revision total knee replacement compared to white patients. So not only is utilization higher in the white patients, but then the issues with failing total knee replacements is actually higher in Black, despite Black patients having lower access, right? So you can start to see there's some fundamental issue in healthcare about how our patients are being treated purely based on the color of their skin. So as I said earlier, we've really bit into this and sunk our teeth into understanding the racial inequities that we're seeing. And at our research program, in our clinical practice here at LSU, we are taking care of a significant number of non-white patients purely because that's the population that we serve and that's the community in which we're in, but also that's part of our mission is to give fair, balanced, and equal treatment to all the patients in our community. So we started a research project looking at the patients that present to our office with NeoA and understanding what their symptoms are based on racial differences. So we took all of our NeoA patients and we characterized their demographics, which you can see here. You can see we actually have in this group a higher percentage of non-white patients compared to white patients. You can see we've got a significant nice spread in terms of insurance type. You can see the severe OA, bone-on-bone OA versus the non-bone-on-bone OA, BMI, Charlson Comorbidity Index, and then the KOOS scores, our pain and function scores, that are now pretty much the standard when it comes to CMS, trying to figure out and try to measure quality. And what did we find? So the patients that came for their initial visit, their first new patient visit that had a diagnosis of NeoA, what did we find? What we found was a significantly worse score with KOOS symptoms, KOOS pain, and KOOS ADL. No significant difference, statistically significant difference in KOOS quality of life. So Black patients, when we control for BMI, when we control for Charlson Comorbidity Index, when we control for gender, when we control for KL score, when we control for all these variables, what we found were the non-white patients were coming in for the same level of arthritis with significantly worse symptoms compared to our white patients. We also wanted to look at how our non-white patients were doing compared to our white patients in the context of a pretty, what I would say, bread and butter surgery, arthroscopic meniscectomy. And so what we found was our non-white patients were actually starting off at a lower point compared to our white patients prior to knee arthroscopy for meniscus tear. But what we found post-operatively was a little intriguing. Our non-white patients actually caught up to the white patients 90 days after their knee scope. So in other words, they were different going into surgery, but the surgery actually equalized and normalized the relationship between white and non-white patients. So in other words, there was an access issue, but when given access, the patients were actually able to equalize and perform at the same level. So if given the chance, what we're seeing, at least in this, with a fairly bread and butter surgery that doesn't require a lot of resources and fairly straightforward post-operative recovery, we're able to actually level the playing field, if you will. What we did find, however, was a difference by insurance. So the Medicaid patients did not do as well preoperatively and did not do as well post-operatively. So what this shows is actually access to resources and access to care is actually one of the biggest gating items and influences in terms of how patients do, not necessarily the color of your skin. So if you can get them access, patients will actually do well. And so the barrier is really access. And so the color of your skin goes hand in hand with access. But if we can tease out that difference, we actually can move the needle and make a difference. We're also additionally trying to understand and figure out what are the basic science drivers around the differences we see in outcomes. And so in our patients that are undergoing total knee replacement, we're actually cataloging and warehousing their tissue in a tissue repository or a biobank on our total knee replacement patients. And so what we found is at the time of surgery going into a total knee replacement, we see a statistically and clinically significant difference in our Black patients compared to our white patients in their KOOS pain, KOOS symptoms, and KOOS ADL scores. What we found also was there was a difference in range of motion in our white patients compared to our Black patients, both preoperatively and postoperatively in our total knee replacement patients. So remember, total knee replacements is a much more resource intense procedure, much more sensitive to access to care compared to our arthroscopy study what we were doing. And then we looked at some of the basic science explanations of why our Black patients may have decreased range of motion and worse symptoms both before and after surgery. What we found interesting was that we actually saw a difference in synovial fibrosis in our non-white patients compared to our white patients. So the next question then is why? What are the environmental drivers? Maybe it's nutrition, maybe it's access to care, maybe it's a number of variables that we have to do a deeper dive into. But what we're seeing is these social determinants of health are actually impacting our patients biologically, which is then impacting their outcomes following more complex surgeries, such as knee replacement. So both acute and chronic pain in Black patients has been shown to consistently be different and undertreated in our non-white patients compared to our white patients. They're also more likely to underreport their pain. Black patients, again, have an access issue, 40% less likely to receive a total knee replacement, despite increasing utilization of total knee replacements over the past 10 years. And we can see they're at a much higher risk of having a revision knee replacement, despite having poor access to that surgery to begin with. So despite most of our population being Black or non-white, these individuals continue to experience higher rates of health inequities compared to their white counterparts. Orthopedics has the least racial and gender diversity of all medical specialties. So why does this matter? So why do we still have inequities in 2020? So there's lack of awareness of racial inequities, especially amongst some physicians and some providers, thinking that they themselves have no bias, but we'll get into some of the explanations of that. Possible lack of empathy. When you have privilege and you may not live the life of some of your patients or understand what they're going through simply to get to your office, maybe they didn't have bus fare, maybe they had to change 3 different buses, maybe they ran out of gas money, what have you. Do you really understand what our patients are going through? Inadequate emotional regulation. Clinicians with good emotional regulation are less likely to stereotype patients. And then interracial anxiety. White clinicians who want to avoid prejudice can develop anxiety when interacting with minority groups, which results in lower quality judgment and negative body language, which then leads to this concept of implicit racial bias. And so the 2 types of bias are explicit bias, which is what you'd expect from someone who's overtly racist that you see on the news or that we've come accustomed to over the decades. But really the more insidious type of bias is this implicit bias or unconscious bias, nonverbal behaviors, body language, and this has been assessed and validated with tests of physicians and all other professionals. And it's something that potentially providers and physicians can do a better job of monitoring themselves. So with that, I would like to thank you for your attention and understanding and appreciating some of the challenges that we have in healthcare, that we have really a moral, ethical, and economic imperative to try to improve and hopefully solve. So with that, I will pause and hand it over for comments and questions. Thank you for your time.
Welcome back, everyone, to our Q&A component of our session with Dr. Dasa and myself. We'll go ahead and get started. Please use the chat room to ask questions you might have from either presentation. We will try and moderate the discussion both on the chat room, and for some of the questions we'll elevate it obviously to a more interactive discussion. So one of the first questions that has been put on the chat room is, what does the economic data say about LAPIS for all fractures? That's a great question. Obviously, you want to get your fractures to heal. You want to do what you can to facilitate fracture healing in our patient population and not lead to the morbidity associated with a non-union or a delayed union in terms of time off work, pain. Obviously, currently, we're also facing an opioid epidemic and trying to keep them off pain medications because their fracture hasn't healed. You can see how this can spiral. And so there probably is some value, but the cost benefit has to be assessed or addressed. The TRUST study, which I briefly mentioned before, looked at doing bone stimulation, ultrasound stimulation for all tibia fractures, and it didn't really show utility. Now, there were some issues with that particular study, right? There was issues with the patients actually doing the stimulation on a consistent basis, which we know is important. But again, a lot of these patients are healthy, normal hosts, and we know that most fractures want to heal. So I think you have to look at your patient and recognize, which fracture pattern are you talking about? Also consider the patient as a host. Are they high risk? Are they diabetic or morbidly obese or a vasculopath or have a metabolic issue that might delay or impair fracture healing? And I think all of those things need to be taken into account in an effort to optimize and tailor your care for the patient. So I don't use a LAPIS for every fracture I treat, but I definitely have that conversation with patients. And I also give them some of them a chance to heal on their own. And if I'm not happy with their fracture healing in a certain sort of period of time, and we talked a little bit about, diagnosing a delayed union or non-union, but if they're not behaving the way I want them to, then I will sometimes initiate LAPIS maybe earlier than another patient who has a very similar fracture pattern. So I think there are a lot of factors that go into it.
Thanks, Samir. I've got a question here on our disparities talk. So the question is, has there been any subjective studies from the patient's perspective on whether or not racial disparities are seen on their end and how they would rate it and what they would like to see change? So there's two predominant types of bias. So there's implicit and explicit bias. So explicit is kind of what we would expect, KKK and stuff like that, where people are obviously racist and biased. Implicit bias is the subtle biases where you don't necessarily exhibit overt bias, but you have nonverbal and behavioral and body language clues that may clue you in that you may have some bias going on. And so if we look at
I don't mean to interrupt him, but like an example of that would be when, a patient calls one of my female residents a nurse.
Right. Yep, exactly. So we've got gender, we've got sexual orientation, we've got racial biases. So it runs the gamut. And then if we do a deeper dive on that, we look at something called aversive racism. And this may be where a lot of physicians fall in and don't realize it, where you've got very low explicit bias, but you have high implicit bias. And the term aversive because you consciously believe in racial equality and consider being racially biased as being aversive. That's not who you are. However, your verbal behavior versus nonverbal behavior may not be congruent. So you more likely may have anxiety when interacting with non-white patients or patients of a different race. You may exhibit decreased eye contact when dealing with Black patients versus white patients, depending on kind of that implicit bias you may have that you may not even realize. These clinicians, by the patients, actually view these clinicians as being less trustworthy because of the incongruence between how they say and how they act. It's one, when you're explicitly biased, you kind of know what you're dealing with. when you have implicit bias and aversive racism, it gets even more scary because you don't know what you're dealing with as a patient, where someone is saying one thing but acting a different way, right? Because they're uncomfortable, or they don't necessarily believe, their actions aren't mimicking exactly how they believe. And so what we find is the lowest level of Black patient satisfaction, even when compared to clinicians with both explicit, high explicit bias, when physicians exhibit aversive racism, again, which is low explicit but high implicit bias. So the perspective on the patient side, even though we may not necessarily think we're behaving this way, the way they're interpreting it is different. And so we have to be very sensitive to who our patients are. They're not cookie cutters of each other. And it can be by religion, right? And I often talk about an example where I had a patient who was Muslim, and her husband accompanied her. They were devout religious patients, and he did all the talking, right? And so she didn't want to make the healthcare decisions for her. He was making the decisions on her behalf, but she was abdicating that ability to him. And so we were booking her for surgery. And so what is your, based on how you're brought up, how you were trained, what your belief system is, how do you react in that circumstance, right? Because what we believe growing up in this culture here is very different than other religions and other cultures. And so that's a kind of a more obvious example of where you may feel uncomfortable, and that discomfort may project itself as being untrustworthy, or you just don't understand, right? And then take that even to a deeper level where you may have some biases based on race or sexual orientation or what have you. So I think if you flip this around and try to look at it from the patient's perspective, it's extremely important that you realize what you maybe think you're saying and doing is not necessarily how it's being interpreted.
So, I mean, to carry forward on that discussion, one of the questions that came up is, do you feel that physicians give different post-op information and care depending on patient's race? And I'm going to jump on that a little bit.
Sure.
So I do orthopedic trauma for a living, and I have a fairly wide range of patients, from people who are flying from other states to see me to operate electively on them for their fracture care, to people who may be coming in incarcerated, right? So I have a spectrum of diversity, gender. Trauma happens to everybody. People break, everybody of every race, creed, and color breaks something. And so I think, again, if I knew my biases, they wouldn't be implicit to some degree. I mean, I think if you're aware of them, you can then act on them. I do think that I manage my patients based on the resources that they have in terms of post-operatively, whether it's braces or equipment or durable medical goods, obtaining something in the hospital. Do I admit patients to be able to operate on them because they may not have the right insurance or insurance at all because it's the right thing to do? Yes. And sometimes it may be perceived, there may be some differential treatment, not necessarily based on their race or gender or creed, but more based on whether they have the ability or the resources to be able to get the care that they need. But and I don't know the literature on this, Dr. Vin, you probably know the literature better on this, especially in the arthroplasty world, where I think a lot of this work has been done already in orthopedics. But there probably is a little bit of information differential between, and not maybe, again, not explicitly, but there probably is some differential information given to different groups, because it's the same information that's given to all groups, right? Like my post-op instructions for an ankle fracture don't differ by race or gender, but maybe they should, right? Maybe there needs to be a different approach because of differences in access to care and that sort of thing. I don't know, but it brings up a really good point.
Yeah, and I don't think, I don't want anyone to think we have all the answers. I think everybody agrees this is so insidious and so deep rooted. We're not going to solve this and give you the answers here in 15 minutes. This is going to take probably decades, if not centuries, to unwind. And so what I think the goal here is to simply bring this to top of mind and for everyone to understand and start thinking about it. What is your little role you can play, whatever spheres of influence you can influence to try to move the needle? Because I think it's collectively, all of us individually, one by one, adding what we do to the global solution. And so, we're not going to solve this today, but, there are barriers, right? And so Medicaid patients simply don't have access to care like others do, right? And so what do we do with that? We're not going to solve the funding issues with Medicaid. We're not going to solve the banking and housing and all those problems, those systemic issues. But, we have to simply do the best we can. We have to recognize it. And, do you withhold care or change your care, because you just make assumptions that this person may have Medicaid when in fact they don't, right? There are probably people that walk into your office or your emergency room and you start making assumptions and drawing stereotypes without actually looking. That person could be the CEO of a Fortune 500 company, but because of the way they're dressed and the way they look, you all of a sudden start drawing conclusions and making assumptions. And listen, I'm just as guilty probably as anyone else. We're all human, but we have to recognize that we've got inherent biases, and we have to kind of try to take a step back and intellectualize what's going on, because I think even today and yesterday and the day before, I think we all agree we've got to do something. We've got to move the needle, and we've got to understand kind of what's going on systemically.
And I'll go on. I mean, one of the questions that came up and you started to touch on it was, how do you help? And I'm going to paraphrase the question. I apologize if I missed something on this, but how do we, how do you suggest we recommend or overcome the barriers with respect to providing care to those with Medicaid type insurance or offshoot insurances that are like Medicaid plans, and that's access to SNFs, reliable home health PT, social factors that play imperative roles in post-op period for TKA, and I would argue for any surgical procedure. And I think one of the things that I would like to see is everybody to do their part, right? We know that, not everybody is going to have the necessary resources or maybe the right insurance. But one of the things that I see in our geography is that certain hospitals take the brunt of helping those, with maybe limited or lack of insurance. The role or the reality is that I think if we all did our part to participate in the care of all patients, it would help decrease the burden on any one provider. And I think that's an important part of this as well. Recognizing there are needs for some change in terms of how insurance is done and how resources are sort of managed externally for patients. And, I don't want to get into a talk about universal health care, but, there's a whole other realm out there. But for what we have right now, if everybody did and took part in the care of the patient appropriately that comes to them, it would probably make a huge difference in terms of offloading everybody.
So the next question here is, thank you for the great presentation today. Is there any data available, or perhaps even your thoughts and clinical experience, Dr. Dasa and Dr. Mehta, which may suggest that advocacy or increasing the numbers of minority clinicians or having a greater number of racially diverse providers in the orthopedic surgical space may potentially decrease the biases and racial discrepancies with regards to treatment and management of minority or racially diverse patients? So
absolutely.
No, go. And no, go ahead. So where we see evidence of this is actually out of the OBGYN literature. And what we find in that literature, and there was actually a paper just published in JAMA, I think last week or even 2 weeks ago, looking at the mortality rates of babies. And when you have congruence of the physician and the baby, not the mother, but when the race of the physician was congruent with the race of the newborn baby, the death rate and mortality rate of the baby went down, okay? Versus when the race of the physician and the baby, again, not the mother, the baby, was discordant. And so that's, to me, an eye-opener, right? Where the physician and the baby actually had to match up in order to see the most optimal outcomes. And when we looked at the mother, the impact wasn't there. So if we look, and again, orthopedics, the problem is there's no data. I mean, probably Samir and I represent the maximum amount of diversity in a lot of departments right here on one Zoom. And so, You just don't have the research and the data to do a deeper dive in orthopedics. But again, if we look at other specialties, you can start to see and start to understand what's out there. And I suspect that translates over into specialties like ours that are historically really homogenous.
Yeah, and the question is well worded and well said. There are discrepancies, and we know that there's also, from a patient perspective, there's a trust issue as well. There is data to show that patients tend to trust people that are of contiguous, of congruent race more so. And so there is data to show that that may also improve access to care and actually engagement with care. And again, Dr. Dawson probably knows the data better than I do in whole joint literature, but total knee arthroplasty, if you are a minority, you're less likely to get a total knee arthroplasty for similar symptoms. And is part of that has been ascribed to a potential distrust of the medical system, because you're dealing with somebody who may not be, for lack of a better word, like you. And that goes to that JAMA article that, if you have not read, I would encourage you to read. It's really eye-opening. And I think one of the issues, and one of the things that comes up, is we need to do a better job in medicine, orthopedics especially, to help with that diversity. But it doesn't happen. It can happen in terms of getting medical students to do orthopedics. But the pipeline has to start earlier, right? We need to get more medical students in who are diverse. I mean, that means we need to get more diverse students into college who want to go to medical school, because we can only select from the medical students, right? We can't take somebody who's not a medical student and make them an orthopedic resident. So the process has to start early. And there are groups out there that are going into the schools and going into local environments to help encourage people on this path, so that then we have that body to choose from. And many of departments are doing this in light of many of the events happening nationally right now. We now have or will have very shortly, a vice chair of diversity and inclusion at the University of Pennsylvania. Every department must have a vice chair, not just a member, not a director. It's been elevated to a vice chair level at every department of diversity and inclusion. And we also know that if you don't have a diverse faculty, it's also harder to recruit diverse residents. There is data to show that even if you have faculty from a different department who are engaged with your applicant process, so we have, for instance, a plastic surgeon who works with us to improve our diversity sort of pull, we know that there's data to show that actually helps increase the diversity within your own program. So seeing diversity within an institution can help bring more diverse applicants in.
Yep. I think there's a lipus question here, Samir.
Yeah. So it sounds like people want to know, how do you choose between lipus or not? Are there areas where you wouldn't do lipus? So one of the things that I encourage or talk to about my patients is, lipus is an option. But if you have a situation where you have a unstable fracture, where the hardware has failed, active infection, you have instability, malalignment, these are areas where putting a lipus on is not going to be successful. You really need to be in a situation where you have a well-aligned limb. There's limited to no infection. There's limited to no malalignment. The hardware is intact. So it's a relatively stable environment. And that's when I will offer my patients the option. And many patients sometimes are not ready for something invasive like an exchange nailing or an open bone grafting. And they want to try something that's conservative to make sure. And honestly, for me, sometimes I almost want my patients to ask me to do a surgery on them, because at least they have then tried to manage their situation non-operatively or conservatively. So I think but you have to have the right mechanical and biologic environment to do that. Dr. Dawson, have you published your LSU study? What journal was it in? And they'd love to read it.
Yeah, so the data that I presented, we have 3 studies, one around NeoA, black symptoms at presentation, black versus white, one on our arthroscopy patients, black versus white, and then Medicaid versus non-Medicaid. And then we've got a couple other health disparities publications. Those are all in manuscript form right now. So we're revising, editing, all that kind of stuff. So I'm hoping we can get those submitted by the end of the year and maybe early next year out for formal publication. So stay tuned. I wanted to present this early data in this forum. You know, it wasn't peer reviewed officially, but I think it was compelling enough given what's going on that I wanted to get that data out just so we can start discussing this. I think it's too important to simply sit on it and wait for a journal to publish it. But again, it's not peer reviewed. This is our data that we're working on. So, you know, you can decide what you think of those numbers, but I thought it was important enough to get it out. Let's see. I think those were the last two questions.
Great questions. Really
So I think on behalf of Samir and myself, really appreciate taking time to hear what we've had to say. Hopefully enhance your career, your practice, and your patient care, and you know, improve how you manage fractures and arthritis.
I'll see you guys a little later this afternoon to talk a little bit about COVID.
Take care.
Take care, guys.